Welcome DIKWP, 小攻 aboard. Your learning journey starts now. Ever feel like drug selection is a shot in the dark? Like you're juggling data, guidelines, and gut feelings all at once? What if I told you there's a framework, a cognitive map, that can make this less of an art and more of a science? We're diving into the DIKWP model, and trust me, it changes the game. So, what's this DIKWP magic? Forget the old pyramid. It's a dynamic web. Think of it as five interconnected layers: data, information, knowledge, wisdom, and purpose. It's not just D to I to K to W to P. It's a whole network of interactions, 25 distinct paths between any two elements. Why does this matter? Because clinical decision making isn't linear. When choosing between acetaminophen and ibuprofen for a headache, you don't just look up the mechanism. You start with the patient's data, interpret it into information, apply your knowledge of pharmacology, use your wisdom considering comorbidities, and ultimately aim for the purpose of pain relief without harm. This model forces us to explicitly consider these connections, making our reasoning transparent and robust. Let's get specific. Rheumatoid arthritis pain, nasty stuff. You've got loxoprofen and diclofenac, both NSAIDs. Diclofenac hits hard, great for severe inflammation, but carries higher cardiovascular and GI risks. Loxoprofen is gentler, faster onset, better GI profile. How does DIKWP help choose? Look at the scores. Diclofenac often scores higher in paths, linking information to knowledge, I to K, and knowledge to purpose, K to P, reflecting its potent anti-inflammatory action when inflammation is confirmed. But loxoprofen frequently leads in paths involving wisdom, W, and purpose, P, especially when considering long-term safety and starting therapy. It's a classic trade-off: powerful weapon versus reliable workhorse. DIKWP quantifies this, guiding the clinician towards a safer initial option or a targeted escalation based on the cognitive path taken. Now, antibiotics. Cefuroxime, a second-gen cephalosporin, versus levofloxacin, a fluoroquinolone. For common community infections, cefuroxime is often the go-to. It's generally safe, effective against typical suspects, and crucially, pregnancy compatible. Its strength lies in paths emphasizing information to wisdom, I to W, and wisdom to purpose, W to P, aligning with the principle of using the narrowest spectrum possible. Levofloxacin is a powerhouse, broad spectrum, great for complex or resistant infections, but comes with significant black box warnings regarding tendons, nerves, and even aortic issues. It scores high in data to purpose, D to P, due to its wide reach, but lower in wisdom-related paths because of those risks. The DIKWP analysis clearly shows why we reserve fluoroquinolones. They're reserved for situations where the data strongly suggests a need for their unique power after careful consideration of the wisdom layer. This isn't just about comparing two drugs in isolation. DIKWP really shines when dealing with complex patients. Pregnant women? The primary purpose shifts heavily towards fetal safety. This immediately filters options, favoring agents like cefuroxime over levofloxacin or famotidine over many PPIs for reflux. Chronic disease patients? They often have multiple targets. An ARB like valsartan might be preferred for a diabetic hypertensive, not just for blood pressure but for renal protection, a higher level knowledge to wisdom to purpose path. Elderly patients? Polypharmacy is a nightmare. DIKWP guides us to simplify, start low, monitor closely, and favor agents with fewer interactions or risks, like amlodipine for hypertension or H2RAs for GERD over long-term PPIs. It's about navigating the intricate web of interactions specific to each individual. So, why should you care about this DIKWP framework? Because it provides clarity amidst complexity. It offers flexibility, allowing us to weigh different factors appropriately. Crucially, it integrates the cold, hard logic of data and evidence with the irreplaceable value of clinical wisdom and experience. It helps us avoid cognitive traps and makes our reasoning explicit. Ultimately, applying DIKWP leads to safer, more rational, and ultimately, more effective prescribing. It's not just another acronym, it's a powerful tool for structured thinking in the art of medicine. That's the DIKWP advantage,